Today I'm talking again with Rachel Ward, psychiatric nurse practitioner, and one of the clearest voices I know when it comes to understanding neurodivergence in clinical practice. And this conversation matters because the research is becoming impossible to ignore. Over the last decade, large-scale studies have shown that neurodivergent adults, especially women and assigned female at birth individuals, are routinely misdiagnosed for years before anyone recognizes ADHD or autism beneath the anxiety, depression, or treatment-resistant symptoms they've been carrying. So today we're pulling this into the light, how neurodivergence gets missed, how it gets mislabeled, and how clinicians can stop treating the smoke while overlooking the fire. If you're a clinician, this is essential listening. And if you're someone who has always felt like you were handed the wrong operating manual for your own brain, this episode might give you language and relief you've been searching for. Let's get started. Welcome to The Missing Piece, Cracking Therapy's Toughest Cases. I'm your host, Heleen Woest, and I'm a licensed professional counselor. Today, I'm thrilled again to talk with Rachel Ward, and this time on the hot topic of neurodivergence. Welcome, Rachel.
Thanks for having me.
Of course. Rachel is a board-certified psychiatric mental health nurse practitioner and the medical director and founder of Something Human Mental Health in Portland, Oregon. She specializes in working with complex patients who have historically struggled to find their footing in the mental health system. She also takes a holistic, relational approach, blending lifestyle changes, herbal therapies, and spirituality with Western medicine, and that is something I absolutely love. I actually have personal experience of that. Rachel has been helping my daughter who deals with a lot of issues. Rachel actually put her on a stimulant, and I was shocked because she's been put on everything else but that. She's actually have autism. And she has a lot of anxiety and depression, and we've tried all the medicines. There was, in fact, five years of trial and error that we did, where they literally are just throwing something against the wall and see what sticks, right? But then bringing her to you guys, that was just amazing. So can you explain why that was the right call for an autistic brain and why standard treatment like SSRIs often fall short when it comes to people with neurodivergence? Yes.
Yeah. This is a really big topic. The neurodivergent brain is so different. And I think about, I actually really wish they would rename ADHD and autism. I've been talking to a lot of colleagues about this. Well, first of all, attention deficit disorder it's not an attention deficit, it's attention dysregulation disorder. And I think we've talked about this a little bit. Yes. I kind of think of ADHD and autism as kind of like two hands of the same coin, is they're both a consequence of dopamine dysregulation in the brain. But where that shows up based on the 28 different genes that could be effective, whether it's your dopamine transporter or the synaptic space or whatever area that your specific genetic profile and your environmental activation of that profile can lead to dopamine dysregulation in the brain. Okay. And so if you start to think about where in the brain that's happening, so if it's in if dopamine dysregulation is in the movement cortex, you're going to have hyperactivity or even hypoactivity in some people. If it's in the midbrain, there can be addictions because the satiation pathways are not satiated. There can be emotional dysregulation. There can be like bringing in too much information into the body. That's one of the core symptoms of autism. If it's in the prefrontal cortex, that's a lot of the things that people talk about, and you hear about that a lot, the executive function piece of spatial planning, working memory, differentiating small details. But specifically to your question, in ADHD and autism, it's not it's not a deficit issue. It's a lack of brakes in the brain.
Huh. That's interesting.
So it's like you're driving a car without brakes. And that's why the anxiety is happening. So in the midbrain, that part, it fully develops and on time. But the prefrontal cortex is delayed or doesn't develop fully. And people who are neurodivergent, we're seeing that their brain fully matures around 35. It's really late.
Really? I didn't know that.
And on average, teens are 7 years behind their peers. So the thing that I like to kind of pull up to help people visualize what this looks like is a teenage brain looks a lot like a neurodivergent brain under normal physiology. So they have very fast 0 to 100 reactions. They are very passionate. They fall in love quickly. They're more impulsive.
Yes, for sure.
So it's very similar. Like the normal teenage brain is very similar to an ADHD brain.
Wow.
But if you take ADHD and add it on top of that, it becomes even more pronounced.
Okay. Wow.
So
a teenager then with a teenage brain.
With a teenage brain
ADHD
and ADHD. Now you have this very pronounced, 0 to 100. It's like tantrums almost, impulsivity, where they're making what we grown-ups feel like are inappropriate choices.
Yes.
But also very passionate. They tend to be very excited about things, think deeply, and create wonderful things.
Exactly. There's these very beneficial things too.
Yeah,
right? Yes.
yeah. And so, but it's like driving a car without brakes. So if you think about normal anxiety that you would have, your normal emotional response, that emotional response is not inhibited by anything in the neurodivergent brain. If you give that person serotonin, first of all, they already have enough serotonin in most cases. And so the only thing that you're giving them is emotional dullness. You're flattening everything.
Yes, I've heard clients say that.
Yeah, they feel very flat. And that's not healthy.
No,
like
it isn't.
You want to feel the full range of your emotions. That's important. That's an important part.
Absolutely. I've heard clients say this. It's like, I want to be me. And this SSRIs make me feel like I'm not me. I'm just like this person that's dull and boring.
Yes. And in fact, sometimes I see people who are put on SSRI as a teenager and then continued into mid-adulthood. And when they come off of the SSRIs, they don't have the skills to be able to manage their emotional landscape.
Oh, wow. So dysregulated a lot.
Yeah, I think it's harmful because they don't have that distress tolerance.
Exactly. They didn't create the tools to regulate themselves.
Correct.
Right?
Yeah. But in the case of a person who's neurodivergent, so we give them an SSRI, they become flat, and they're kind of better.
Right. Yes, I guess so. It makes me think a little bit like the lobotomy. I don't know why my mind's going there. It's like put that thing in the brain. Oh, they're better.
They're kind of better.
They are brain dead
but
now.
they're kind of brain dead.
Yes.
Yeah.
Wow.
But if you give that anxious neurodivergent person a stimulant, it gives them breaks. So they feel the full range of their emotions, but they have a split second in some cases, but a split second might be better than nothing of time in between I'm having an emotion and I'm having a reaction to that emotion. And that little space, every time you flex that muscle, it strengthens the prefrontal cortex. So actually in the first year of treatment, after you've been on a stimulant and you get that little space of time, the prefrontal cortex grows.
Yeah. Wow.
So there's some curative effect too for these people.
Yes, we talked about that before.
Yeah.
They don't necessarily have to stay on the things forever.
Yeah, or not as high of a dose.
Not a high dose, yes.
But yeah, so now they have this little bit of time to decide what their reaction is going to be. And that every time you flex that muscle of self-control, of emotional tolerance, emotional distress, it becomes easier. And the anxiety decreases. So that's one piece. The other side that's really tricky is that norepinephrine can bind to dopamine receptors in the brain. That is a normal physiologic response. That's what happens when like the mom lifts the car off of a baby.
Oh, okay. Yes.
Okay. So
we've heard of,
yeah. Norepinephrine's another word for adrenaline in the body.
Okay.
But specifically it's adrenaline in the brain. So norepinephrine floods your brain and it binds those dopamine receptors under an emergency and allows you to focus.
Okay. Yes.
So people who just don't have enough dopamine at the receptor sites for whatever reason, usually they will have found ways to recruit from that norepinephrine system. That can look like creating false urgency, doing way too many things in your life all the time.
Okay.
I mean, it can look a lot of different ways, but
like
those are the
crises
everywhere, creating a lot of crisis.
Yes.
Yeah,
yes.
Kind of creating a lot of chaos around yourself.
Interesting.
And even that can look very normal. So that can look like they just are functioning at a very high level. Like they've got a whole bunch of kids and they've got a fancy job and they keep their house completely perfect.
They're always busy.
But then when the door closes, they just fall apart. So in those people, that overuse of the norepinephrine system over time leads to fatigue of cortisol, where cortisol is not as effective. Okay. And norepinephrine feels really anxiety driven. It's very anxiety driven.
Yes, no, for sure. That high adrenaline.
Yeah, feels body. And the sleep gets dysregulated, and it's kind of a cycle that feeds into itself. So if you give that person a stimulant, at first they'll feel very tired.
Okay. Because they don't have that.
They don't have access to that.
Yes.
And it feels like you feel like a superhero. You feel amazing. You feel like you could do anything. Yeah.
Yes.
So it feels kind of like a letdown to focus on dopamine instead of norepinephrine.
Yeah.
But if you inhibit that binding of norepinephrine over time, the anxiety will come down as a response too. And they can learn to not create chaos in their life.
Wow. So there could be an initial rise, but then it comes down. Is that what you're saying? Or is it not necessarily a rise at the beginning of anxiety? It's rather...
Usually those people feel, I call it the anxiety buddy. Like they had an anxiety buddy that was helping them do a lot of stuff. But the anxiety buddy is kind of a false friend.
Okay. That's a good way to put it. Yes.
And then we remove the anxiety buddy and now they're very tired until we get the stimulant to the right place. But it's just a very different type of focus.
Yeah, that's fascinating because I would have never thought to give somebody with ADHD or somebody with that
anxiety.
Kind of anxiety, to give them a stimulant. Well, could you say a little bit more about the link between autism and ADHD? Because, when I do, I've heard you explain it so eloquently, but it's still hard for me to explain to people what's the connection. And we were even talking about the genetic connection, then going down family line. But specifically, I like your analogy of the two hands of the same body, right? Autism and ADHD. So could you say a little bit more about that?
Yeah. So in studies that were done, and mind you, studies are in psychiatry almost universally are done on men. So
that's not fair.
It's not fair. It's not fair, but that's the data we have. But the heritability rate, or not heritability rate, I got ahead of myself. The overlap between comorbidity between ADHD and autism is 80%.
Really? This is in studies that they found that? Wow.
Very high. Wow. Very high.
So you will maybe have both. Is that what you're saying?
For sure.
Okay. There's a big chance.
Yeah.
Wow.
Yeah. And in fact, I usually only test for one. I only test for ADHD. And if I diagnose ADHD, I assume that you probably have autism as well.
And you find that a lot too, that there will be those same sensory disorder problems.
Oh,
and
for
all
sure.
of that in the person who has ADHD too.
For sure.
Wow.
Yeah.
That is fascinating.
Almost, it's like very extremely rarely do I find somebody that it feels like pure ADHD. And even then, it's like, it's only a matter of time before they're like, oh yeah, I just wear the same clothes every single day.
Yes, these are the only ones that don't scratch me.
Yeah,
and don't feel bad.
Yeah. And because the problem is also with both ADHD and autism, there's a very big difficulty with interoception or understanding what's going on in your body, knowing what your symptoms are.
Yeah, no, that's fascinating. I had no idea about that, but we do see it in family lines too, right? It's like you spoke about that specifically, is that usually if you're treating a teenager with this, very likely the mom or dad or both could have been undiagnosed, but they have similar things going on in them.
Yeah, there's a theory that birds of a feather flock together.
Yes.
Like people with the same way of thinking, same neurotype will do the same hobbies and same careers, and so they will find each other and marry each other and have children together.
That makes sense.
But on top of that, if one child is so what the American Psychiatric Academy recommends is if we diagnose a child, we recommend the whole family be assessed.
Okay.
Because if one child is diagnosed, then at least one parent has it. If two children and their first degree, their full blood siblings have 50% chance of having it.
Oh, wow.
If two children are diagnosed, then both parents have it and everybody in the family has it.
Oh, wow. So it is a family affair.
It's a family affair.
Oh, my goodness. Yeah. And actually, I've also seen where somebody has such a high degree of it, say autism 3, right? So they're nonverbal and everything, and the focus are so on them that the other kid also has something, but they just fell through the cracks.
Yeah.
Yes, because it's not as huge, but the chances of them having also maybe autism 1 or ADHD or both, right, is actually very high.
Yeah.
Wow.
And the other thing is too that sometimes parents will have come up with coping mechanisms in their household and kind of created a neurodivergent oasis or really normalized symptoms because everybody has it. Right. Everybody does it.
So it's normal.
It's very normalized. Yeah. Yeah. And so people are like, well, no, everybody is picky eaters or everybody.
Yeah. And then you're looking at them like, no, not really. No, not really. It's not a thing. I can see that happen for sure. Yes. The normalization. I mean, that's just true for all types of things in families, right? Where many times people tell me, oh, they had a lovely upbringing. There was nothing wrong. And then when we start to dig a little bit, there's like 7 aces, right? So there's just all these adverse childhood experiences. But to them, it was just normal.
Oh, it's very normal. Everybody has that.
That was just a Tuesday, man.
Yeah.
Yeah. Now I can see the normalization of neurodivergence too, right? Yeah. So could you talk to us a little bit about, well, let me first say this. There's 2 testings I want to talk about. I want to talk about genetic testing and then also the ADHD testing specifically that you do, which again is unheard of for people to do it out the gate. And I am so in awe of you guys doing it that I had you over so you can talk to all my colleagues, right? Because I think it is something that's being missed, because if you don't have those components or if you don't know this person has a neurodivergent brain, and it's not always so easy to tell by just seeing someone, then you're going to prescribe the wrong thing, right?
That's exactly right. Yeah.
So talk to me about those tests a little bit.
Yeah. So the test that I use in my practice is called CREYOS, CREYOS, and I always tell people it catches about 90% of cases.
Wow, that's pretty good.
Which is pretty good. Yeah. And the reason I started using it, interestingly, is that I was finding a very hard time differentiating between personality disorders and autism.
Oh, really?
Yeah.
Huh.
Because personality disorders are so stigmatized.
Yes, very much so.
And people want to believe that they have autism.
Okay.
And so I was finding it very difficult to differentiate between the two. And so I needed a tool that could help me. We have so few objective data in psychiatry too.
Not an exact science, right?
Yeah.
Still, we're struggling. There's not enough. We don't know enough.
Yeah. And so I use that, and then let's say it's negative and I'm still suspicious of ADHD or autism. I may send them on for neuropsych testing, which is the gold standard in psychiatry.
Like the boundary of testing. That's about
with a psychologist. It's expensive. That's the other thing, is that it's
very expensive.
While it is the best way, it's very expensive, it's time consuming, it's hard to access. And we need objective data and good diagnosis. Our patients deserve that.
Yes, especially if you're going to prescribe them things to put in their body. And it needs to be as accurate as possible.
Exactly. Right? Yeah. Plus, on top of that, as I started using the tool, I was like, actually, this is useful in so many other ways, because it tells me exactly where they are struggling in terms of their executive function. And so it becomes a really useful tool for creating lifestyle interventions that are specific to the patient.
Wow. That makes sense.
Yeah. And monitoring them as we go through therapy to see where they are in terms of their function, whether it's working or not.
Wow. So, because just treating executive functions, problems with executive functions, very vague, right? So this test helps you to actually, to actually point to certain areas and be like, this will be good to have some behavioral help with this.
Exactly. Right? Yeah. Okay. Yeah. So it tests 5 different areas. It's looking at spatial awareness, which seems like that shouldn't have anything to do with ADHD, but it totally does. That's like, people talk about like assembling furniture without instructions, or
yes, okay, a light's going off in my head.
You're like, but also like the task of deciding how long something's going to take and creating a block that you're going to put on your calendar. That's a spatial awareness task. And then, so that's one. Another is working memory. That's like your ability to hold a set of data and draw from that data in order to complete another task.
Okay.
Another one is differentiating small details. So that's important for like multiple choice exams, like test anxiety that can show up, or people who really like perseverate around decision making, have a lot of anxiety around decision making.
Wow.
Or impulsive decision making, because you can't tell what the difference is, and so you just pick something and move on.
Oh wow.
And then emotional reactivity, so difficulty with emotional inhibition.
Yeah.
And then ability to perform when something is boring.
Oh, the boring thing.
The boring thing.
Yes, I just told you earlier on, right? Maybe I'm just bored again. Because some of those neurodivergent traits that come up is boredom, and could be
novelty seeking.
Yes, because even detrimental to the point of not being able to hold a job, right? Because this job is so boring, or I need something new. I'm done with this now. So I can see that could be very debilitating for sure. Well, so this test actually, I want one of those tests. I need to give it to my clients, because I'm like, this seems so smart to know those things, to know the actual details. Right?
It's really
because
helpful.
You can just help clients so much better.
Having something quantifiable.
Yes,
again,
exactly.
Like I always come back to that. Like psychiatry is so qualitative.
Yes,
we really need quantitative data.
We really do, don't we? Yes, that's one of the reasons I love EMDR, because it's at least a quantitative element there that I can use.
Hold on to.
Yes, exactly. Well, and genetic testing. This is also the first time ever I've heard of this. When you told me, like, you want to do genetic testing with my daughter, I'm like, what? So explain a little bit how this actually interacts with psychotropic medication.
Yeah, so this is very important, especially in neurodivergence. I think even more than other disease processes in psychiatry, but and I'll talk about more about that in a minute if you remind me. But what it's actually testing for is how well your receptor sites in your liver work. essentially. So it's looking at the different receptor sites and deciding whether you are a fast metabolizer of medication or a slow metabolizer of medication.
Okay.
The other thing, as I started using it more, and there's a couple other markers that they have on there. One is has to do with the metabolism of your own hormones, which is super important, especially for women.
Yeah.
I've seen that abnormal in men's tests, but I haven't really figured out what to do with it with a men's test yet, because there's just not data.
Yes, the area on their side where there's very
not
little
tested
data.
or studied at all. And then let's see, it also tests for it's called COMT. That it has to do with the metabolism of your own neurotransmitters, which is very important for understanding. It's not diagnostic in and of itself, but understanding whether or not you have a buildup of dopamine and serotonin, norepinephrine in your brain, or whether you metabolize it so quickly that you just don't have enough of it available to you. And so that can guide medication decisions in a certain way.
Yeah, for sure. I can see that. Well, can you say just something more about the buildup? I'm sorry to have to interrupt you, but this is just something the buildup.
You're like, what? That's not, everybody's talking about adding more. Yeah. And that's not always the best thing.
Wow.
So what I have found, especially with OCD type, like fear-based disorders, is they will have a genetic profile that is met. That means that they are slow metabolizers of their own neurotransmitters. And if you give that person an SSRI, they have OCD, and the first line treatment is a high dose SSRI.
Oh, it'll
they will feel terrible. They feel it's the worst. It's the worst.
Goodness.
You have to give that patient an antipsychotic.
Wow.
Because it's the only type of medication that decreases neurotransmitters.
Wow. That's mind-boggling to me.
Right?
Yeah.
So using, again, objective data to try and help psychiatric patients.
Yeah, and genetic testing, because it runs in families, right? That's before even thinking about genetic testing will work for that. I remember a psychiatrist telling me, like, whatever worked for you might work for her.
Exactly.
Because in family lines, it
runs in family lines.
Yeah,
and we've known that for a long time, but a lot of people are very hesitant to adopt the genetic testing. Don't feel like it's a evidence-based tool.
Wow.
But how could it not be?
Yes, how could it not be? Exactly. Plus, so many times people in the older generations, they've never been diagnosed with anything. So they had this stuff, but they don't have the pulse. They can't say, like, for me, I can tell my kids this kind of medication worked for me. It will probably work for you. But we don't have that.
We don't have that data.
No. Hence, genetic testing. Right?
Well, even if we did have that data, like sometimes I'll have a parent who tried a lot of things and is very against Western medication, has been burned.
Oh, yeah.
Because they had, hallucinations from an SSRI or whatever weird thing happened to them.
Yeah, it didn't work.
And very reasonably don't want their kids to be on meds when meds really could help.
Yes.
And so understanding which metabolism pathway the medications are going through, understanding, like, maybe this medication could work for you, but maybe we need to do a very low dose. No, we really don't want to give you birth control because it's going to make you psychotic.
Oh, wow. Those things you can actually pick up in genetic testing. Wow, that's amazing.
Yeah.
Can we talk a little bit about just the stigma surrounding medication, though? Because I feel like when I was in college, one professor who did the neuropharmacology with us, right, was talking specifically about this, said, like, some things need to be medicated. And so he wrote the 3 on the board, and I can still remember that. He was saying ADHD, and then schizophrenia, and what was the other one?
It's got to be bipolar.
Bipolar, yes. See,
I was trying to decide if it was going to be the same ones that I would say.
Yes.
Yeah.
And so tell me a little bit what your thoughts are on that. Do you believe that really, say for instance, a parent tells you they want you to help this kid, but they cannot go on any medication, Western medication. They don't believe in that. They don't want you doing any of that. But this is a kid with ADHD, maybe even severe ADHD in front of you, and knowing that actually a stimulant the only thing that can treat it? Or is it?
That's a loaded question.
I know, there's a lot. It's like 10 questions in one.
Stimulants are by far the best treatment for ADHD.
Okay.
They are effective 90% of the time. That being said, it's understandable that people don't want to take Western medication for one reason or another.
Yeah.
And I think we talked about it a little bit earlier too. The benefit of taking medication, you have that brain growth over time, so there is benefit. And all of our patients are on their own journey that has nothing to do with me.
That's true. So you will never press the issue.
No.
Right? You will try and find something else.
I'm going to find, because also the even more important than the right medication is the relationship that I have with my patient.
Yes.
Because if they can trust me, then maybe down the line we can try something else that would be more effective.
Yes.
But if I haven't earned that trust, they have no reason. I have no right to demand that they do something with their body. I don't have any right to demand that they do something with their body anyway. But
right. No, I know exactly what you're saying. I mean, the relationship is so crucial.
Yeah.
Even the data shows that, right? In therapy, for instance, the relationship is the biggest.
Yeah, more than the modality,
yes.
more than any other thing.
I mean, first of all, it's the client that walks in the door. That's the biggest part, right?
Yeah.
Whether they're ready to change, whether they're in a place that they can change. But then when it comes to the therapist or the clinician, it really is the relationship, the modalities and stuff, like you just said, is like 1%.
Yeah.
It really doesn't matter that much. And I agree with you, because I do get that a lot, actually, clients who do not want to go on any medication. I'm thinking in the back of my head, I've got to send them to Rachel, because this sounds like ADHD or whatever it is, right? But they are not ready for that, or they've had some bad experiences, like you said, specifically because they have a neurodivergent brain and they didn't get the right medication for that. But then again, sort of walking it through with them, because many of them, well, they come to see me because I do trauma, right? And so I'm like, we will do all the trauma treatment, we will do the things, and then we'll talk again about medication afterwards, right?
It'll come.
So there's also sometimes a time for it, I feel, because at some point I did tell myself, man, why didn't you just see this? You should have been on medication ages ago. But then thinking back about this conversation of they were not ready.
They weren't ready.
So just like people are sometimes not ready for therapy, they're just not ready for medication.
That's right.
So what are some of the alternatives that you go to?
Yeah, so saffron's my favorite.
Saffron?
By far and away. Yeah, it raises dopamine, norepinephrine, and serotonin.
Oh, wow.
So it can be used as an antidepressant, but also, especially in kids, it can be used as a treatment for ADHD to kind of get started.
And it's effective?
It's effective. Yeah.
Okay.
Yeah.
Wow.
I wouldn't say it's not as effective as a stimulant. Nothing is as effective as a stimulant.
Yes, because it works instantly, right?
Yeah. But if you have, let's say, a family where they are very supportive and well-regulated, they're doing a lot of behavioral interventions for the kiddo, they've got a lot of supports in place at school, saffron can be a great treatment to do instead. Or if they don't want to do a stimulant, they're kind of nervous about that, guanfacine is a really good option for kiddos with ADHD. Which is Western medicine. But sometimes if it's not a stimulant, it's a little bit less stressful. Yes,
because parents are always afraid also, just like with benzos and all the other things, afraid of the addictive factor that there is. So what would you say to a parent who's worried that their kid they're gonna get hooked on a stimulant?
That's a reasonable concern. So what I usually tell people is, and in fact I wrote a blog post about this, is that it's kind of like giving blood pressure medicine to somebody who has a blood pressure problem versus giving blood pressure medicine to somebody who does not have a blood pressure problem. Okay. And you can imagine the consequences that would come. So, if you give somebody who has normal blood pressure some losartan, they're going to pass out.
Yes.
But if you give somebody who has really high blood pressure some losartan, they'll they'll feel fine.
They'll survive.
They'll feel better.
Yes, much better. Yeah.
And in a neurodivergent brain, the dopamine levels are very low, or they're not reaching there because the transmitters are working, or whatever the problem is. So if you give them a stimulant, they're coming up closer to neurotypical levels.
Okay.
So the risk for addiction in a neurodivergent person is significantly less than it is in a person who is neurotypical.
Okay.
Because when you give a neurotypical person a stimulant, they feel high.
Right, exactly.
Yeah.
Where, like you said, it just for a neurodivergent person, it just brings it up to a normal level where they're not running with weights on their legs anymore.
That's right.
You know, they can be normal, if you will, whatever
Closer,
that means.
yeah.
Yes, and closer. Never normal.
Don't oversell.
Yeah, don't oversell. I won't. Good point. Well, I wanted to ask something more about specifically that part with the meds. We made a little turn there at addiction. Do you also then get maybe a lot of people who come to you with addiction who are neurodivergent, but the addiction really happened because they didn't have the right medication, because they were just not sensory seeking, they were dopamine seeking.
Oh,
right?
This is one of my favorite topics.
Well, hit it.
People are so afraid to medicate people with substance use with a stimulant.
Mm-hmm.
They're
Always.
so afraid. And the reality is, there's a couple realities about this, is that addiction and neurodivergence are comorbid 75% of the time.
Really?
That
is so high.
It's so high.
It's just sort of like a given.
Yes, almost a given. Yeah. Yeah. And whenever I have somebody come to me who is struggling with addiction, the first thing we do is we go through every substance they've ever tried. And I ask them how it made them feel, how long they took it, how much they took, what it reacted, what was the come down, because that is so much data. They have tried so many medications before I even got to them.
Right. That was self-medicating every time.
They tried so many medications. Yeah. So, for example, somebody has a history of cocaine use. Mm-hmm. They are a person who is going to need a very high stimulant to be effective.
Wow.
And the research shows this.
Why is that?
The cocaine, it interacts with, it breaks down the receptor sites.
Okay.
But B, if they were using cocaine to just kind of get through their day, they probably had severe ADHD
to begin with
and needed that support badly.
Yes. And then, I mean, people try so many things, right? We spoke briefly about pornography. They, eating disorders, that looks like an eating disorder, but really it's just trying to get dopamine out of that food. Binge eating disorder especially. Right?
Yes. And actually eating disorders are the same. It's the same neuro pathway. It's the same disease process as substance use disorders.
Wow. That's why Vyvanse get off-label prescribed for binge eating disorder.
Yes.
That makes a lot of sense.
Yes. Yeah. And so usually what I do very first, we go through all the substances they've ever tried. And obviously I'm not going to put somebody on heroin or something heroin adjacent.
Hopefully not.
But, if they're telling me, let's say that it was a lot of impulsivity and when they drank alcohol, they used oxycodone, they just felt a lot less impulsivity. You better bet your bottom dollar I'm going to try naltrexone for them.
Yes.
Because that's satisfying the opioid receptor without getting them high.
Yes.
You've tried a lot of medications because we're destigmatizing substance use.
Yes, we are.
I was like, you've tried a lot of medications. If I can find a better medication for you, would you be willing to stop that one? Because I have ones that have fewer side effects.
That's a good way to put it. That seems very tempting to me. It's like, yes, please, ma'am, sign me up.
Yeah. And so, just taking away the shame around it. But then also it's like, as you start, I don't even try to wean people off of substances before I start treating them.
Wow.
So we start treatment, and as their other symptoms improve, substance use naturally declines. And then we get down to a very low level. They're doing therapy at the same time, and they are able to come off. I'm telling you, like, I don't know, 9 times out of 10, maybe more. It's really, you destigmatize it, take the shame away, treat their core symptoms, and then the substance use resolves on its own.
Wow, that is fascinating because, yes, we still do not have good modalities to treat substance abuse. But what if that was never the problem?
What if that was never the problem?
We are treating the smoke here, but there's a fire that we're not even looking at.
Exactly.
Right? Yeah.
Yeah.
Wow. Now that's actually very hopeful.
Yeah.
I think people listening to this and hearing that, because, there must be a lot of clinicians out there with neurodivergence too, which brings me to another thing that we talked about before, people being very smart, right? And I forgot what the name was for that, but you did.
Twice exceptional.
Twice exceptional. Wow. Yeah. Well, talk more about that. That's super interesting.
So having very high intelligence all in of itself is sort of its own neurodivergence.
Really?
So even without being neurodivergent, when you're you kind of think about like the absent-minded professor.
Yes. Oh yeah, I was thinking of just that.
It's like they have so much of their brain function devoted to higher level thinking that they struggle with basic tasks.
Yeah.
And then if you add neurodivergence on top of that, it can create a lot of chaos. But
I can see that. Yes, that could be pretty hard.
Yeah, and they can be very high functioning in some areas and very low functioning in other areas.
Yes.
And that can create a lot of cognitive dissonance around your sense of self, because why am I able to be a complete boss in this area and I'm a mess over here?
Yes. Yeah. I've actually heard that Intel started these groups for autism because so many of the engineers they're on the spectrum somehow.
Oh,
right?
For sure.
And that they've actually did that, just realizing this is a big chunk of their population.
It's a thing. Yeah. Wow. I think there was a study I read that like 7 in 10 medical professionals have some type of neurodivergence.
Oh, really? Oh, goodness.
It makes sense if you think about like the norepinephrine system, the chaos seeking,
Yes.
Yeah, it makes a lot of sense. So thinking deeply, anyway.
Wow. Okay. No, I'm learning a lot about myself too. And that's probably a good thing. Probably not a bad thing, right?
Yes.
Wow. So just neurodivergence in general, it became like I said a hot topic at the beginning, because right now it is everywhere. So it's on TikTok, it's everywhere, people talking about it, saying, well, everybody has some autism and that kind of stuff. With a lot of things that's happening with this generation just being so smart and having all this knowledge at their fingertips, but not everybody has it, right?
Correct.
So, well, what do you say about that? And do you actually have people wanting you to diagnose them so badly?
Yeah, I got to be careful because I don't want to create stigma, but that definitely does happen. And that's part of why I started using that Craos test and to help me differentiate. But yeah, I mean, I talk a lot to especially teenagers about normal development. And we kind of talked about this a little bit, is that normal development in a teenager looks a whole lot like ADHD.
Right.
It's impulsive, it's emotionally reactive, it's passionate, and, so not all teenagers look a little bit neurodivergent, but not all teenagers have neurodivergence.
Okay, so maybe also a reason why it's so prevalent under teenagers, right? Talking about this and thinking that they all have it.
Yes.
I remember talking to parents often when they want to know this. They're like, oh, how do I know my kid has any kind of mental disorder, or they're just a teenager, and so that's where testing come in. Very valuable.
And that's really important because the importance of early treatment. If you can get that brain growth early enough and not have the struggle of the poor sense of self that happens from the negative reinforcement from being neurodivergent, it's so important. But we need that objective data.
Early intervention, right? So important. I always wish in kindergarten everybody would just be tested because it could be so helpful.
Yeah.
My daughter, for instance, was diagnosed only pretty late, and all those years. So we knew she had sensory disorder because, you know, she was just tiny when she started like taking off those socks everywhere and can't handle clothes that itches, all the things. But that happens a lot too, misdiagnosis or
just finding a piece. Like I'll have teens come in and say they've been to an audiologist who diagnosed hyperacusis or like very intense hearing.
Yeah.
And I'm like, well, that should have triggered them to look into autism.
To look further, yes.
Yeah.
So again, just that staying with the client and listening to them instead of just running with something, because that I have to always be careful of that I listen and wait it out and listen for more, because it's so easily for me to hear something and my brain just runs with it. And I'm like, ooh, I know what's wrong with this line. This is what's happening, you know, and instead to be like, I don't want to fix everything with a hammer here. Let me pull back a little bit and see if I see all the pieces.
The importance of that differential diagnosis.
Exactly. We're coming to the end here, but anything that we missed that you still want to talk about neurodivergence, because it's a huge topic, right?
And it's a huge topic.
Is there something that comes to mind for you?
There's one other thing that comes to mind often is the differentiation between trauma and neurodivergence.
Oh, yes.
You said that, and it made me think of it, because trauma causes differences in memory and sleep. And
exactly. And it can look like brain injury. Right?
Exactly. And that's not a person who's going to benefit from a stimulant typically.
No, not at all. No. So even that, right? You're also looking at that, looking if this is maybe we have to get a therapist on board here too. And there's
always a therapist.
Always a therapist.
Always a therapist.
I like that a lot.
I tell all of my patients, I'm like, I'm only 50% of the work here. Don't take a pill and run off.
Well, you know, isn't it true for so many things? I'm telling people, like, actually, we should all have acupuncturists on hand. We should all see regularly a therapist. All the things, you know, because life is hard. There's a lot of things that happen.
Yeah, and we can't expect our primary person we love to be all things for us, right?
Yes, exactly. So you also, even if it's somebody who didn't speak necessarily about their trauma, you will also test for that, for PTSD?
Always.
Okay. Yes, I like to hear that because yes, it's like you just said, it's a huge difference in the brain too, right? The brain is also running at a very high adrenaline and cortisol. If people it's the same vigilant state, isn't it? But it's just triggered differently.
From a different way.
Yes. Yeah. That fight and flight always going.
Oh, yeah.
Which, if we can speak of that for a second here, is very debilitating. It can make people very ill, right? So we're not made to stay in that state.
No. Yeah. And that's the same state that's happening when you're using that norepinephrine system, your anxiety buddy, to help power your function. It's the same thing. It starts to look a lot like trauma.
Yeah. And sometimes they do overlap, right?
Exactly.
Can we say that too?
Well, yeah. And then the incidence, the likelihood of experiencing trauma when you have ADHD is higher.
Why is that? Do you know?
Well, if you think about the impulsivity and creating chaos in your environment, and it's like kind of setting yourself.
I hear what you're saying. Yes. No, definitely. And even just so somebody had undiagnosed ADHD, undiagnosed autism, it can create its own trauma in the sense of something is wrong with me. People treating you differently, and you're looking at people around you and they're not acting like you're acting, and it's that feeling of something is very wrong.
Something's wrong with me fundamentally.
Yes. So,
or if you think about the emotional inhibition and you put that in a whole family system, that can create a lot of messy family dynamics that can lead to trauma.
Exactly, because it does influence a lot of relationships, right? Yeah. It does play out in relationships.
And that speaks to the overlap between borderline personality disorder and neurodivergence.
Again, so there's a lot of things to tease out, because I have made lists and stuff of just looking at the overlap between borderline and complex post-traumatic stress disorder, because those two look the same. So much so that Dr. Schwartz, who, did internal family systems or developed that, he says that, he doesn't really think there is such a thing as borderline. It's all complex post-traumatic stress disorder, because you treat for the trauma, and then so many times now this person who had borderline, many other clinicians said they had, doesn't have it anymore.
Yeah.
So, and then do you find the same thing? Is that actually this borderline person come to you and you medicate or give them the right medication because you tested them, and it was actually autism or it was something else, ADHD?
Absolutely. But the overlap is so high because of the emotional inhibition piece. But, complex PTSD and borderline really is the same diagnosis.
Yeah. Isn't it? Yes. Yeah. That's what I feel too.
But I always tell people, I'm always kind of excited when I diagnose borderline or see PTSD, because that's something you can heal from.
Yes. I say that all the time. We can treat trauma. This is the good news.
This can go away. ADHD doesn't go away. That's kind of an annoying diagnosis to get. Yes. But the trauma one, I'm like, okay, good. Like, we can fix this.
It's treatable. Yeah. Yes, trauma is treatable. Thank goodness for that, right?
Yeah, exactly.
Yeah, but I love how you just look at all the overlapping and all the things. And I really think we should. That's why I'm hoping this podcast will be helpful to other therapists. I said at the beginning, if you find a puzzle piece on the table that we didn't, why don't you bring it in? Because there's definitely so much to look at. And I think we should never stop learning, right? Because as the field develops, we have to keep our finger on the pulse for those things, because they're very important.
Absolutely.
I think we have seen nothing yet. I'm actually very excited about where the brain's going to go, right?
Me too.
Hopefully one of these days we can just zap a certain part of the brain and person is totally cured.
Boy, that would be amazing. I don't know. I don't know if that'll happen, but
maybe
fingers crossed.
In our lifetime. Maybe when pigs fly.
Maybe when pigs fly. That's right.
Well, as always, Rachel, so much fun having you. I just love talking to you about all these things, and I'm going to have you back for some more of these topics. But thank you so much for bringing your expertise and also your compassion, for your clients. It just shows when you talk about it, shows that you care about people. You don't care about the money. You don't care about the meds. It's the person in front of you that you care about. And that's truly inspiring.
Thank you.
Again, if you guys want to hear more about Rachel and all the wonderful work that she does, somethingmentalhealth.com.
Somethinghumanhealth.com.
Somethinghumanhealth.com. So sorry, Rachel.
That's okay.
But yes, and also you find links on there to her blog. She was referring to some blog posts. She writes excellent blogs. So go and read some of those, and you can contact her. The place again, or the business that she has, is Something Human Mental Health. Thank you for joining me. I'm Heleen Woest, and this is The Missing Piece.